We'll look at the demographics of traumatic central nervous system injury, a little bit about different ways to classify traumatic brain injury, and of course, for the most part, we'll be looking at an imaging approach in understanding the injury patterns. We'll end up with a short discussion on the use of non-contrast CT and patterns of fractures, which are particularly predictive of vascular injury, so that we can help triage those patients appropriately. Now, I have no relevant disclosures to point out at this point. Now, traumatic brain injury is very common. As you can see in this graph from Dr. Jean, it dwarfs all other types of brain diseases, with over 2 million traumatic brain injury cases per year. Every 15 seconds, someone has a traumatic brain injury in the United States alone. Every 5 seconds, someone is permanently disabled by traumatic brain injury. And it's a leading cause of death and disability in younger patients. The estimated cost, both personally and financially, is quite staggering. Over the last several years, actually, falls have overtaken motor vehicle accidents as the most common cause of brain injury. Now, if we look at who gets brain injury over time, this is the age group going by decades, we can see there's a peak in our late teens and early 20s, and another peak as we get over age 65 or 75. The blue bars show that men are disproportionately represented in central nervous system trauma. It isn't exactly clear why this is, although there are some clues from the literature about activities that men engage in versus more sensible women, but we'll leave that for another discussion. Now, how can we classify traumatic brain injury? Certainly, there are many ways that give us sort of a shorthand for communication, also for research studies. The clinical severity using the Glasgow Coma scale, imaging severity, timing. Is this a primary injury at the time, or is it secondary as a complication? What's the mechanism of injury? And the location, of course. And we'll be touching on all of these since they're used usually in combination to understand. Now, one of the most important clinical scales is the Glasgow Coma scale. This scale goes from 3, which is essentially no function on eyes, verbal, or motor, up to a normal scale of 15 for a perfectly normal patient. As you can imagine, as you take points off, we get lower Glasgow Coma scales, and these correlate at least roughly with categories of injury. So 13 to 15 would be mild, 9 to 12, moderate, and 3 to 8, a severe injury based on this clinical grading scale, which is simple and reproducible. There are other ways to look at it, the post-traumatic amnesia time, the length of consciousness disturbance, etc. But the GCS is the one I think most of us use. Now, if we are to approach the injury, we have to have a pattern like any other type of film or examination. And I think the one that makes the most sense, most experts, including Professor Parazel, I've heard him speak on this, start with the outside and go in. And this is how Elisa Jean also looks at it. And one of the keys here is just to dust off some of our neuroanatomy, and in particular the anatomy of the meninges, which are critical for understanding the patterns of blood. So you'll remember, of course, that the pia mater, the delicate part of the brain, covers the surface of the brain. It's a thin single-cell layer. The arachnoid comes from spider. It looks like spider web here with these little trabeculations. That's where the CSF and the blood vessels run. The dura mater, the tough mother, this tough coating, which is the inner periosteum of the skull, splits off around dural reflections like the falx and, say, at the optic nerve. And then we, using that information, can classify why different blood collections occur where they do. For example, with trauma to the scalp, we may see scalp